All right, hello everybody. Welcome to this week's Wednesday webinar. We're going to give it some time to let the room fill up quickly, and then we'll go ahead and get started. All right. Thank you all for joining us this week. We're going to give it just one more second before we go ahead and get started. All right. Well, good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on von Willebrand's disease and joint bleeds. My name is Alson Murtha, and I'm the Manager of Strategic Communications here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. If you're streaming from one of our social media platforms or YouTube channel, you can go ahead and ask your questions in the comments. We have NHF staff members monitoring these questions, which we will post to our speaker after the presentation. This webinar is being recorded and will be available to the community beginning Friday, November 18th. I'm joined today by Professor Eikenboom, all the way from the Netherlands. Thank you for taking the time to join us today. I'll go ahead and turn it over to you to get us started.
Okay, thank you for the introduction. So I'm Jeroen Eikenboom. I'm from the Leiden University Medical Center. You see the picture of our hospital on the first slide. And I'm an internist trained in hematology and vascular medicine. And I'm working at the Department of Thrombosis and Hemostasis in Leiden. And mainly my work from the point of clinical duties and also research is focused on Willebrand disease. And I'm very pleased with the invitation to talk to you today on Willebrand disease and joint bleeds. Just as a short disclosure, I am not have no financial conflicts. Only I received some research funding from CSL Behring, but it has no reflection on the presentation that I give you today. So what will I discuss during this webinar? I will first focus a little bit on the mechanisms of the hemostasis system and a short brief introduction again on Willebrand disease. Probably you know already a lot of Willebrand disease, but I think as an introduction to this lecture, it's good to have some, again, some rehearsal of your knowledge on Willebrand disease. Then I will focus specifically on the symptoms of Willebrand disease, and that will finally focus on the symptom of joint bleeds. And I will also go into the mechanisms and the consequences of joint bleeds. And the final part of my presentation will focus on the treatment options for specifically the problem with the joint bleeds. So first, I would like to give some background on the complex regulation of blood coagulation. It would be so nice if the blood coagulation system would be very simple, like this machine with just a on and off switch. So to put it on when blood should clot and to switch it off when no more clotting is required. But in fact, in the physiological situation of the person, there are many switches and dials that are all together making the coagulation system work. And with some dials going up, you have more risk of thrombosis, and some dials going down, you may have more risk of bleeding. And this is a very complex regulated system. And actually, the mechanism of hemostasis literally means the stop of the blood flowing, so the stop of bleeding. The main aspect of the mechanism of hemostasis is the first situation that may occur when the vessel wall is injured. So as long as blood vessels are intact, blood will remain fluid and flow through the blood vessels to supply the organs with nutrients and oxygen. But when the vessel wall is injured, you need an instant start of a coagulation system to stop losing blood from that injured vessel wall. And after the vessel wall is injured, there are a few responses that occur. First, there will be a reflex of the body that make the that causes a reduction of the blood flow by reducing the size of the blood vessel. So there is a constriction, a narrowing of the blood vessel that reduces the blood flow and thereby reduces the blood loss. But that's not enough. You do not only need to reduce the blood flow, you should actually stop the bleeding from the hole in the blood vessel. So the hole in the blood vessel should be closed. And that's done by the formation of a platelet plug. So platelets are tiny cells in the blood that clump together and form a plug to close the hole. And this combination of the reduction of blood flow together with the formation of this plug of platelets that close the hole, that together is often called the primary hemostasis. And the primary hemostasis, so that's the first defense mechanism to close the hole in the vessel. However, if this would be the only mechanism, then after a short period of time, this platelet plug will fall apart again and you may start bleeding again. So there's also another phase of the blood coagulation, and that is also triggered by the vessel wall injury. And that's a complex mechanism of all kinds of clotting factors in the blood that end in the formation of fibrin. And fibrin is a protein network that is forming a network around the platelet plug, and it makes the platelet plug more firm, that it will not fall apart again. And this second phase of the coagulation system is called the secondary hemostasis. Patients with hemophilia have problems with this part, so they lack factors that are involved in secondary hemostasis. Whereas patients with von Willebrand's disease, they lack von Willebrand factor, and von Willebrand factor plays a role in this platelet plug formation. And depending on the severity of the von Willebrand disease, you may have mainly a problem with the platelet plug formation. But if you have a very strong reduction of von Willebrand factor, you may also start to have problems in the secondary hemostasis, because not only your von Willebrand factor is low, but also your coagulation factor 8 will reduce in concentration. Together, these two phases of the primary and secondary hemostasis is what they call hemostasis. And of course, then there is in the end a final step, which is important in the step of the wound healing. The clot is also removed again, and that's what we call fibrinolysis. But for the rest of the presentation, we will focus mainly on this part of the platelet plug formation, which is so important in von Willebrand disease. This entire mechanism of the coagulation system can be considered as a balance. And on the one hand, if it does not function well enough, you may start bleeding. If it functions too good and it's not inhibited at the right time, it may cause thrombosis. So the mechanism should be in a right balance to prevent either excessive bleeding or the development of thrombosis. And for instance, if you have not enough factors that are actually procoagulant, which means stimulating the coagulation system, if you have less of these factors and you have more of the anticoagulant factors, so the factors that inhibit the coagulation, if this is in imbalance, you may have a problem with bleeding. But vice versa, if you have too much of the stimulating factors and not enough of the inhibiting factors, you may end up with thrombosis. And in von Willebrand disease, actually, you are in this situation in the middle. So what happens in von Willebrand disease? So if you, I sometimes illustrate it like this. So if you consider the platelets in the blood as bricks, you will need a mortar or cement to stick the bricks together. And actually, that's what von Willebrand factor is doing. And together, the platelets and the von Willebrand factor together will form a brick wall, and you have a platelet plug. If, however, you lack the cement or the mortar, or that it doesn't is not bad, if it's a bad cement, you will end up with an unstable wall or an unstable platelet plug. So that's more or less to illustrate what's wrong in von Willebrand disease. So after this short introduction on the mechanisms of the coagulation system, I will move on to really more the subject of today. So, sorry, this is the last slide summarizing everything that I've told you so far. So for Willebrand factor illustrated over here in this red protein in the blood, and this is streaming in the blood in a somewhat coiled configuration. But when the vessel wall is injured, so when the endothelial cell that protect the vessel wall, if it's damaged, Willebrand factor gets into contact with the damaged vessel wall, and then it will unfurl. So the coiled Willebrand factor will unfurl, and that's how it's activated. And then the platelets, these are those purple platelets, then they can start sticking to Willebrand factor. So after this mechanistic introduction, I would like to move to the clinical symptoms that are present in Willebrand disease. And we, in the Netherlands, we have set up already several years ago a study in which we have included actually, well, we try to include all patients in the Netherlands. And as it's a small country, it's possible to indeed have nearly all patients in our country in this study. And patients were included in the study when they had at least Willebrand factor or factor VIII levels somewhere during their lifetime below a level of 30%. So they had really confirmed Willebrand disease. And we asked them, so they completed questionnaires on their bleeding symptoms, and that's illustrated in this slide and the next slide. And you can see in the different bars, so the top bar is the percentage of patients having nosebleeds. Epistaxis stands for nosebleeds. Only a few percent in the population has nosebleeds. But in Willebrand type 1, so this is this bar, this is nearly 50%. But if you have type 2, this is somewhat more severe. 60% of the patients experience nosebleeds. However, in type 3, the most severe form of the Willebrand disease, up to 80% of the patients experience these symptoms. And if we look at all symptoms, so you also have bleeding of your skin, cutaneous bleedings, you see that most patients experience these kinds of bleedings. Or when you cut yourself and you have a minor wound, all patients experience this. Bleeding from your gums, also present in many patients. However, more severe bleeding, like gastrointestinal bleeding from your stomach or your intestines, is not that frequent, but at least much more frequent than in the healthy population. Then again, so these are more or less all more or less spontaneous bleedings, but if you experience a surgical procedure or tooth extraction, you see also that in Willebrand disease, most of the patients will experience bleeding. Now, if we move on to the next slide, you see that also in surgery, there is a lot of bleeding. A major issue in Willebrand disease is menorrhagia, so heavy menstrual bleeding. This is really a very important problem and present in nearly, as you see, nearly all women experience somewhere heavy menstrual bleeding during their lifetime. What you see from all these symptoms, they are nearly present in all types of Willebrand disease. If you have type 1, 2, or 3, it does not really matter. They all experience these bleedings. But if we now move on to the bleedings over here, so muscle hematoma, so bleeding in the muscles, or bleeding in the joints, that is especially more frequent in the type 3. And maybe you know also already that in patients with hemophilia, hemophilia A or hemophilia B, they especially experience bleeding from muscles and joints. And it was considered in Willebrand disease that this was not a major issue in Willebrand disease, that it was mainly something from hemophilia. But especially in type 3 Willebrand disease, but also in the other types it does occur, but especially in type 3, muscle bleeds and joint bleeds really do occur much more frequent than we considered in the past. And this has to do with the fact that in type 3 Willebrand disease, you do not only have a defect in the platelet plug formation, so in the really the function of a Willebrand factor. But in type 3, you also have a strong reduction of your factor 8 levels. So in type 3 patients, it could be that their factor 8 level is only 5% of normal. So that is in the same range as the factor 8 levels we see in mild hemophilia patients. So in type 3, there is really a combination of a problem in the primary hemostasis of the platelet plug formation, but also a problem in the secondary hemostasis of the fibrin formation. And together, this defect leads to much more joint bleeding and muscle hematomas like in hemophilia, if you compare it with type 1 and type 2 for Willebrand disease. And especially, we will focus now on the joint bleeding. So actually, what is a joint bleeding? What I just showed you before are symptoms as reported by the patients themselves. But do the patients really recognize something like a joint bleed? Do they know what a joint bleeding is? And you should realize that a joint bleeding really is a bleeding inside the joint. It's not a bruise over your knee. It's really a bleeding in the joint itself. And this is a schematic figure showing what happens in a joint bleeding. So if you look in the middle of the slide, so this is the upper joint of your upper leg, and this is your lower leg joint. And this is the cartilage on the joints that move smoothly when you move your knee. You also have ligaments around your joints that form the capsule. So around the joint there is a capsule, and in the joint itself there is fluid. But the capsule is lined with something that we call the synovial membrane. So there's a layer of tissue over the capsule, and this synovial membrane produces the fluid that is inside the joints. And you should consider this fluid more or less like the grease or the oil that makes it smooth in the motion. When you now have a bleeding in a joint, that actually is, if you look at this enlarged figure, it actually is a bleeding from this synovial membrane. Because the joint itself, like the cartilage, there are no blood vessels in the cartilage. The only site where there are blood vessels is in the synovial membrane. So actually the bleeding in a joint is a bleeding from this synovial membrane. So these cells that line the inside of the capsule. But if this starts to bleed, the bleeding comes into the fluid that is inside the joint. So when it starts, you do not see it bleeding because it's completely inside the joint. It's also not immediately visible on the outside, so you do not see a bruise or a blue spot on the outside of the bleeding. It really is inside the joint. But the blood cannot flow away, so the joint will be filled up with more and more blood, and that really can give severe pain to the joint. At the time that the bleeding starts, it usually starts with an immediate sharp pain feeling, and over the time, over the next hours, it can have a swelling of the joint. And that is illustrated over here. And actually, this is a picture of a hemophilia patient, because although it occurs in Willebrand disease patients, it's not much in the literature on this. So most of the pictures you can find are in hemophilia patients. But what you see over here, the joint of the knee here is swollen. You may recognize this. And in the next slide, this may become even more clear. So this is also, again, a knee joint, but now it's from, you are looking at it from the side. And this is your kneecap. This bone here is the kneecap. This is your upper leg and the lower leg. And again, here it's illustrated that bleeding may be from this membrane into the inside of the joint. But you see that on the top here, this capsule of the joint runs quite high up to your upper leg. And that is because if you move your leg in this direction, this moves up. So you need additional space in the capsule over here. But when you have a bleeding, the blood may also accumulate in this part of the capsule. And that may show also not only as a swelling at this position of the joint, but also above the joint, above the kneecap. It may be quite a lot of swelling, but still actually that is blood that is inside the joint, because the capsule of the joint is up to here. And here you see the swelling, but now you see also something else. So here, what is illustrated is that the cartilage that's on the joint, and the cartilage is very important for a smooth motion of the joint, that the cartilage can be damaged just by the blood that is inside the capsule. It's again illustrated over here. So in the healthy situation, you have this membrane, you have the clear fluid in the joint, and you have this cartilage that is very smooth for a smooth motion of your knee. But when you have had bleeding in a joint, and especially if you have recurrent bleeding, so it occurs several times, then due to the blood in the joint, the cartilage may become damaged. And if the cartilage starts to narrow or getting or completely lost, you can have in the end a very painful joint, because there is no smooth motion possible anymore. Another issue is that due to the bleeding, there may also be some inflammation in the knee, and that inflammation may lead to the fact that this membrane over here, that it gets enlarged and thickens. So the membrane gets inflamed, and when it's inflamed, you know that when tissue is inflamed, it feels hot, warm, and red, and that's because there are more blood vessels. The blood vessels are completely widening, so you have this red, warm feeling. That also occurs in this membrane, but that makes the membrane more delicate and fragile, so you may have multiple bleedings from this synovial membrane. So it's a vicious cycle. You have a bleeding, you get inflammation, and due to the inflammation, you get even more or more easy bleeding into the joint. And repetitive bleeding may end up with severe damage actually to the joint. So here it's summarized again. So what are the consequences? On the left, you have the normal joint, but on the right is indicated what can all be damaged. So you can have damage of the cartilage. So you get no smooth cartilage anymore. You get new blood formation. So neovascularization means that in the inflamed area over here, you can get growth of new blood vessels that in turn may become more easily the focus of a next bleeding. You can also have some kind of kists or holes in the bone, so the bone gets weaker just around the cartilage. And in the end, you may end up with osteoporosis, and that's often due to the fact that if you have a damaged joint, you become less active, you walk less, and that leads to osteoporosis or loss of bone formation. And here you see an X-ray of a knee joint, actually again an X-ray of a hemophilia patient. Here you see what is black over here, that's inside the joint, and that is actually the cartilage is black and the bone is white. But on this side you see that due to the repetitive bleeding, the cartilage has completely gone, and you can imagine that it is very painful if you have movement of bone over bone instead of having cartilage in between. So joint bleeds are a serious symptom that may lead to also physical inabilities. And among hemophilia patients, this is well known, a lot of research done, but with respect to familial disease, hardly any research was done on joint bleeds for many, many years. And some years ago, and I show here one of our publications since, well, more or less since the year 2015, and subsequently, we have published several papers specifically focusing on joint bleeds within this Dutch large registry of familial disease patients. And I will focus a little bit on some of the data that came out of these studies, and especially what is important, that joint bleeds in familial disease patients really may have impact on the quality of life and also on the integrity of the joints. So what did we do in this study, in the Willebrand in the Netherlands study, which is a nationwide study? All hemophilia treatment centers in the Netherlands collaborated in this study, and we included 804 participants with familial disease that had as inclusion criterion in the study that their familial factor levels somewhere in their history were below 30% of normal. We asked all the patients questions about their symptoms, and when we focused on the symptoms on joint bleeds, so JB means joint bleeds, there were 184 patients reporting joint bleeds in their history, and 622 did not report joint bleeds. Because this was a self-reported questionnaire and patients may not be fully aware whether something is really a bleeding of a joint or it was just somewhat swelling or it was more a bruise on the outside of the joint. So to be sure that this was really joint bleeds, of those 148 individuals, we really checked their medical files and looked in the data in the medical files whether it could be confirmed from the medical files whether or not they had a joint bleed. And in 55 of the individuals, we could confirm that they really had joint bleeds. It doesn't mean that the rest did not have joint bleeds, but we could not have firm confirmation that they really indeed had a joint bleed. And we compared the patients that had a confirmed joint bleed with patients from the control group that did not report any joint bleeds, and we matched them. So if there was here a 50-year-old man with a joint bleed, we tried to look for a 50-year-old man from this group. So we matched to each patient with a joint bleed, we matched a similar control familial disease patient that did not experience joint bleeds in the past. And when we looked at this cohort of patients, so all over, all the types of familial disease, so 184 of the patients self-reported joint bleeds, so nearly a quarter of the patients at least considered themselves to have had a joint bleed in the past. But if we break this up between type 1, type 2, and type 3 familial disease, here are the figures, so 100 patients of type 1, 62 of type 2, and 22 of type 3. So among the type 3 patients, so in the entire group of 804 familial disease patients, there were 47 with type 3, but 22 of them, so nearly half of the type 3 patients, experienced joint bleeds. But even though type 1 is much less severe, still around 22% had experienced joint bleeds. And it was more or less the same in type 2. So even though it was considered a rare event, it seems to be quite frequent. And even if we only consider the joint bleeds that were really confirmed from the chart, from the medical files, then still it was quite a high number. So that were 55 from the medical files that we could confirm among 804 patients. That still is quite a high percentage of patients experiencing joint bleeds. It's not really something rare. So which joints do they bleed? Well, we divided this over the different joints. So of all the joint bleeds, 103 were in the knee. So, and this percentage of 56% actually is 103 patients of the 184 that experienced a joint bleed had a bleeding in the knee. So the knee bleeds are the most frequent, and actually that's also the case in hemophilia patients. And bleeding in the ankle, that was more or less the same. So the most bleedings are actually in the knee and the ankle, and this is strikingly similar to hemophilia patients. And probably this has to do with the fact that your knee and your ankle are those joints that experience most of the strains. They carry your entire body weight while walking, jumping, etc. So these probably are most at risk for having bleedings. The other joints are less frequently implicated in joint bleeds. When we studied the patients in which we really had confirmed from the medical files that they had joint bleeds, so these were the confirmed joint bleeds, actually you can see that these were mainly quite severe Willebrand disease patients. So their Willebrand factor activity, the median, so or more or less the mean, 2.5 international units per deciliter when we measure this in the blood. And you should consider this is 2.5% of Willebrand factor, so sometimes indicated as percentages. And their factor 8 activities were at the median level were 17%. And when we call something a median, this means that if the median is 17%, it means that 50% of the patient had 17 or lower, and 50% of the patients had 17 or higher. So it's not exactly the same as the mean, but it's more or less, you can compare it with that. So this is quite low. And if we looked at patients that had a Willebrand factor or a factor 8 activity that was below 10%, it was the case in 68% of all patients. So 2/3 of the patients really, with the joint bleeds, really have quite low levels of Willebrand factor and factor 8 activity. So this means that the joint bleeds are a problem in the most severely affected Willebrand disease patients. Then how is the distribution among the type 3? Of the 55 with confirmed joint bleeds, we see that, again, type 3 is severe, but if now that we have in the confirmed patients only, then we see that in the type 2 and the type 3, they both have quite high percentage of joint bleeds, whereas the type 1 are a smaller part of the patients with the joint bleeds. Well, what then happens to those patients with the joint bleeds? So we also figured, can we identify how often they really had surgery for the joint bleeds? Because you can imagine you may have a joint bleed, but if it's once happening, it does not immediately lead to joint damage. So you may not really have the need for surgery of your joints. So we studied all patients for which we could find that they had large surgery of the large joints. This was done in 79 patients. And interesting to see is that the surgery that was because of joint damage after bleeds, because when you get older, many patients really can have surgery of joints just because you become older and you may have arthrosis. But when we looked at the joint bleeds or the surgery that was specifically done for joint bleeds, then still 26 of 110 of the joint surgeries was due to the fact that there had been joint bleeds. So in Willebrand disease patients, they frequently have surgery also at older age, but a quarter of the surgery of the joint is really due to the fact that they had bleeding in the joints. So what's the consequence then for those patients when you have had bleeding? So it may have impairment on your physical activity. And so we studied in those patients with in the Dutch cohort whether they participate in sports. And actually our patients participate in sport quite frequently. And this may just be walking, or it could be tennis, cycling, whatever. But as you can see, it is mainly the sports that are not very heavy for your joints. So they do not play soccer a lot or cycling or tennis, but they do cycle and they do walk a lot. But does it impair them when they have had bleedings? And the percentage of patients among the type among von Willebrand disease that experience limitations, for instance, experiencing pain or impossibilities to walk for a long stretch. So walking 500 meters or more, or 1,000 meters or more in type 3 patients, quite a lot of patients experience limitations due to their joint status to have to do this. But also carrying your groceries when you have had bleedings in your arms, this may be a limitation. So indeed, having had joint bleeds may really limit your physical activities. And if you compare this between von Willebrand disease patients and severe hemophilia patients or the general population, what can they do and where are their limitations? We see for the sport participation, so that it's between von Willebrand disease patients and the general population, it's not that much different. So the white bars and the black bars, it's not a major difference. But you can see that in severe hemophilia, there is even a less participation in sports, whereas, for instance, in hemophilia, they do a lot of swimming. So they do those sports that have the least effect or strain on their joints. But for Willebrand disease patients usually do not take that much into account when you compare this with the general population. But you can see over here that in cycling and walking, they do this a little bit more than the general population. So they tend to do the least strenuous activities. So this is maybe a little bit of a complicated slide. I just show it to you because in hemophilia patients, there has been a scoring system developed to categorize patients regarding their joint health. So there is a scoring system that is called the Hemophilia Joint Health Score, the HJHS, and we applied that also in von Willebrand disease patients. And it does not matter exactly which figure is over here, but what you can see is that when this figure is higher, you have a worse status of your joints. So you have more complaints of your joints. And you can see that in type 1 and type 2 von Willebrand disease, this is not as severe as in moderate hemophilia A, but if you have severe hemophilia A, you have a worse status of your joints. But in type 3 von Willebrand disease, you see this is comparable to severe hemophilia A. So we should really be aware of this problem of joint bleeds, especially also in type 3, because you may have similar complaints as in hemophilia A. Okay, so that are joint bleeds and the consequences of joint bleeds. So what can we do about joint bleeds? So what are the treatments? Well, actually, the current treatment is you should prevent bleeding. So that may have implications for not doing too strenuous sports, or you may be a little bit, so that's why you may go on to hiking or swimming instead of other sports. But preventing joint bleeds may also mean using von Willebrand factor concentrate infusions during high-risk situations, or even as a prophylactic treatment. And I will talk about prophylactic treatment in the next slide. Another issue, you should, of course, do pain management, and you need sometimes physical therapy. When you really have joint damage, it may end up that you need surgery of your joints. So you need a prosthesis of a joint, or sometimes arthrodesis. This means that you just fuse the joints together, so there is no joint actually anymore. But this is very good for pain relief, and this is often done in ankles. You will not do that in your knee because you cannot bend your knee anymore, but in the ankles, ankle surgery often includes arthrodesis. On the right side, there are some potential future treatment options. And to discuss this a little bit more, I'll go to the next slide that shows that the damage to the joint, as I already indicated, is the thickening of the synovium, the new blood vessel formation. It could be that we focus a little bit more on anti-inflammatory drugs, on drugs to remove the iron from the joint. So we think that the red blood the red blood cells that are in the joint, that the iron in the red blood cells actually damage the cartilage in the joint. And potentially new drugs will be focusing on getting rid of the iron in the joint. So there is development on specific treatment of the joint itself. But the most necessary focus point should be preventing joint bleeds. And when there is a joint bleed, that it's treated with factor concentrate as soon as possible. So I already talked about prophylactic treatment, and there has been a so-called fulminant factor network on prophylaxis, fulminant disease prophylaxis network, and they made a study on patients to see how many patients do actually use prophylactic fulminant factor concentrate treatment and what are the effects of this treatment. And prophylactic treatment means that you infuse yourself with fulminant factor concentrate, let's say twice or sometimes 3 times a week, to have a higher continuous level of fulminant factor, and in that way prevent the occurrence of bleeding. And when they did this inventory, we focus on this blue box. So in patients with the different types of fulminant disease, so they identified individuals using prophylaxis in the hospital that participated, and they looked at the distribution of the patients using prophylaxis. And as you can see, 51% of the patients that used prophylaxis are actually type 3 patients. So among fulminant disease patients, mainly type 3 fulminant disease patients use prophylactic treatment. But also this is quite frequent, that's on the second line over here. 25 or nearly 25% of the patients with type 2A fulminant disease also so of the patients on prophylaxis, 25% of them are type 2A. What's the effect of using this prophylaxis? Well, if you use prophylaxis, some of the patients with type 3 have a very high rate of bleeding, not only joint bleeds, but also nosebleed, gastrointestinal bleeds, etc. And the mean frequency of bleeding per year decreases from 25 bleeds a year to 6 bleeds a year if you use prophylaxis. And this graph illustrates the distribution of bleeds in an individual. So if you look at all types of fulminant disease together, so the blue one are the nosebleeds, these are the joint bleeds, other bleeds, gastrointestinal bleeds, and menorrhagia. If this is the distribution of the different bleeds before starting prophylaxis, when patients start prophylaxis, then it's decreased up to here. And you see that mainly, that's the red one, the joint bleeds are very much reduced. Here you see in type 3, joint bleeds are a major part of all their bleedings, and this is a major reduction of the joint bleeds when they use prophylaxis. So joint bleeds really have a strong reduction in the patients on prophylaxis. And that is also in another study this was found. This graph illustrates what is the percentage in the reduction of your bleeds. And for the joint bleeds after prophylaxis, you had a nearly 90% reduction in the frequency of bleeding. So it also works for less nosebleeds or less heavy menstrual bleeding, but mainly if you have joint bleeds, the prophylaxis is very good in preventing the joint bleeds. So to summarize what I discussed in this webinar, so joint bleeds also occur in von Willebrand disease, and it's not only a problem in hemophilia, and it has not been enough awareness of this among doctors. And also in von Willebrand disease, the bleedings into joint may lead to really physical impairment. And not only impairment, also damage that may in the end result in joint surgery. And physicians should be aware of joint bleeds in von Willebrand disease so they can really stress that there is a need for immediate treatment when there is a joint bleed, and potentially also the use of prophylactic treatment. But it also needs that the patients are more or less educated, that they recognize the joint bleeds, because some of the bleeds are really more bleeding of the subcutaneous soft tissue outside the joint. Those bleedings are not really damaging the joint, but it's really about the bleedings that occur inside the joints. And with that, I like to finish the presentation and we can move on to doing some Q&A.
That was fantastic. Thank you very much. Before we get started on the Q&A, I quickly have an announcement to make. Recruitment is now open for the Own Your Path program for young adult males with hemophilia who are currently in transition years between 18 to 30. We know that maintaining adherence to a prophy regimen can have short and long-term health benefits. This program focuses on helping participants be successful by focusing on education, health coaching, skill building, and relationship building, all within an app-based environment that includes participation incentives. If you have patients in this age range and think it would be a good fit, please email us at ownyourpath@hemophilia.org, and we can send you the flyer to share. For consumers, you can email us directly at the same email address, ownyourpath@hemophilia.org, and we can provide more information or register you directly for the program. Okay, so up next, I do have a poll for you. If you can take a moment to go ahead and answer those quick questions, and I'll get started on the Q&A. If you have any additional questions, please throw them in the chat, and hopefully we have time to get them all. So my first question for you: often musculoskeletal issues in people with VWD get dismissed. How can patients with VWD best advocate for themselves if they believe they have a joint bleed?
Yes, I think that it may occur that they get dismissed and it's not getting enough attention. But you really should be aware of yourself that if you experience a sudden occurrence of pain in the joint, that also have the effect that you have problems in moving the joint, that should be important symptoms that should be made clear to your physician. So if you have a bleeding that's not really in the joint, but more in the subcutaneous tissues around the joint, but not in the joint, usually the pain is not as severe as the pain when it's really in the joint. And also the movement of the joint is mostly impaired by the bleeding in the joint. And in the beginning, when it occurs, you do not see anything on the outside. It may just be the feeling. So this may be sometimes difficult also for the physician to really recognize that there is a bleeding. So it's not easy, but it should be seen by the physician to judge whether or not it's a joint bleed. And nowadays, more and more, ultrasound is used to really confirm whether or not there's something going on inside the joint. Because a bleeding on the outside you can see, but a bleeding in the joint, in the beginning, when it's just a very new bleeding, it may not be visible on the outside. And also the swelling may take time, but preferentially you treat it already before you have this enormous swelling. But it may sometimes be difficult.
Great, thank you. Let's see. Do you think it's important for medical providers, including those in other countries, to collect data on VWD and joint bleeds? Could doing more research on this topic be beneficial for both the medical provider and patients?
Yeah, I think so, because so we have focused on this, but if you look in the medical literature, there's very limited data on focusing on joint bleeds in Willebrand disease. And I think it would be good also to have in other cohorts, not just what we experienced in the Netherlands, but also in other cohorts, to make a study what's really also the frequency in other countries, because there may be differences in treatment regimes, which may lead to different frequency of joint bleeds. So I think that also other cohorts of Willebrand disease patients should be studied for the presence of, or the frequency at least, of those joint bleeds. And another issue, I think, is that from the treatment point of view, the threshold before you start to treat prophylactically should be a little bit lower for Willebrand disease. It's very regular in hemophilia that you do prophylactic treatment, but in Willebrand disease, this still is quite a high threshold before you start with prophylactic treatment. And that should also be more propagated, I think.
Great, thank you. Let's see. As a person with VWD, can your blood type affect how much you bleed?
Yeah, so the blood type, so A, B, or O blood type, does have an influence on your levels of Willebrand factor. With patients with blood type O have a lower Willebrand factor than the other blood types. For instance, even though you may have the exact same genetic defect as some other family member in your family, the ones with blood type O probably has somewhat lower levels of Willebrand factor than the other individuals that have A or B. So it does influence this, and we think that the absolute level of Willebrand factor is the determinant of your bleeding risk. So when we look among type 1 patients for Willebrand disease, we see much more patients with blood type O than in the general population. So there is a trend of lower levels and also more bleeding. But if we focus on the joint bleeds are in the category of patients that are already having very low levels, and probably the additional effect of the blood type O in those already severely low levels is not that significant. So if you are around 40% with your Willebrand factor level with blood type A, you may have only 30 or 28% with blood type O. That may have some influence on nosebleeds, for instance, or menorrhagia. But the patients with joint bleeds often are already below 10% of their Willebrand factor level, and probably it doesn't matter too much if you have 10% or 8%. So I think that the blood type O is not that significant among the severe patients and the ones that then have joint bleeds.
Wonderful, thank you. Okay, so physical therapists are an important part of the multidisciplinary team who educate, evaluate, treat, and rehabilitate patients with musculoskeletal bleeding. Historically, they have been focused on patients with hemophilia. How can we advocate for more PT resources in treatment centers so that VWD patients can also receive PT services?
Yeah, I think you should not actually restrict it to the diagnosis. I think the physiotherapy is helpful in rehabilitation when you have had a major muscle bleed or a joint bleed. And it does not matter if you experience such a bleeding because of your hemophilia A or because of your type 3 Willebrand disease. In both cases, you should actually have access to this physiotherapy to help your rehabilitation. And so I think if there are now obstacles to give this care to Willebrand disease patients, well, then that should really be discussed within the multidisciplinary team, that it should also be addressed to Willebrand disease patients. It's the joint bleed or the muscle bleed that needs the physiotherapy. And it does not matter, in my opinion, what's the disease that caused it.
That's fantastic. Thank you. I know we only have 5 minutes left and I'm just about out of questions. So Len, would you like to have a conversation? I see you're on camera.
Yeah, no, this was a great presentation. I think it's far too often that people with von Willebrand disease don't believe that they can have joint bleeding, and the many clinicians who care for them also are maybe unfamiliar with joint bleeding in people with von Willebrand disease. So it's great to have this kind of data, and our job now is to ensure that all of our clinicians are aware of this information and have this top of mind for when they're evaluating people with von Willebrand disease, that they may have had joint bleeding in the past and are certainly at risk for joint bleeding in the future.
Yeah, sometimes it's considered that, well, it's just arthrosis because you're becoming older, so it's arthrosis. But you should be aware that some of this arthrosis is not regular arthrosis, but actually arthropathy due to bleeding. And we are not aware enough of that. And the previous question, should it be studied also in other populations? The issue is also, it's just mainly Dutch studies. So this does not have this widespread awareness in other countries that this may really be an issue. So when you start this among your own patient populations, there will be more awareness in your country too. So probably in the US, you have this great Zimmerman project on Willebrand disease. So I'm not sure whether it's possible, but it would be nice if they also could focus a little bit more on the joint bleed problem.
Yeah, and certainly through the American Thrombosis and Hemostasis Network, we have the ability to capture joint bleeding in any patient who's enrolled in the registry. So that would be a great opportunity for us to look at the prevalence of joint bleeding in people with all types of von Willebrand disease. Yeah, no, I think this is a great opportunity to raise awareness around the possibility of joint bleeding and the complications of von Willebrand disease.
Yeah.
This is great data. Thank you very much.
Yes, fantastic. Thank you. Well, as we wrap it up, I'd like to just thank you one more time for taking the time to join us this afternoon and share your presentation. I know it's late there, so we appreciate your time and your expertise.
Okay, thank you.
Yeah, I'd also like to thank each one of our viewers for joining us, regardless on what platform you're on. Please note that this recorded webinar will be available on Friday, November 18th at hemophilia.org under the events tab with all of our archived webinars. Also available in the events tab is our upcoming schedule for our weekly Wednesday webinar series. We do not have a webinar next week for Thanksgiving, so just keep that in mind. But thank you for joining us this afternoon and have a wonderful week.
Thank you, Dr. Eikenboom. Thank you.
Bye.